And then, of course, we have a special guest who's live joining us from Florida. He is one of the experts in interventional radiology, Dr. Srini Tumala, who's the president of Amputation Prevention and Vascular Specialist down in Florida. Morning, Srini. How are you?
Good morning, everybody. Thank you.
All right. And then, of course, talking about the interesting case, which people who have seen the flyer, we have a great case here in the lab led by PK and joined by, again, an interventional radiologist, Dr. Rahul Patel and Dr. Guja with the team there to present and see what's the approach of managing a patient in this case. So good morning, PK.
Hey, good morning, everyone, and thank you so much for joining us. We're really excited. There's been a lot of discussion about this case online, and I think it's really a case that's rare, but also something that endovascular specialists need how to treat. I gotta humbly say that it's Dr. Patel who is the expert here. Myself and Karthik are just kind of sitting along and learning along with it, along with all of you on how to deal with such a difficult case. But it's really my pleasure to welcome Dr. Rahul Patel, who's the assistant professor of radiology here at Mount Sinai, really an international expert in any sort of intervention in the endovascular space. Thank you, Rahul. Thank you for making the time to come. And then to my right is Dr. Karthik Guja, who's the director of endovascular services at Mount Sinai, South Nassau. Behind me is Shalini Mani. Shalini is one of our 2 endo fellows this year. Shalini's from Chennai, India. She's planning on going back to India and starting a program there. Behind Rahul is Ray Lascano, our interventional NP, and our nurses today are Mac and Alina, and our tech today is Ramon, and of course we have Damien as well. So without further ado, we're going to get to the presentation. Go ahead, Shalini.
Good morning, everyone. Next slide, please.
Give a little bit more. Yep, give 3,000.
Next slide, please.
Next slide, guys. Yep.
Today, our patient is a 46-year-old woman who initially was hospitalized at an outside facility with symptoms of chest pain, shortness of breath, and vague abdominal pain. The initial triple CT protocol was done to rule out acute coronary syndrome, pulmonary embolism, and aortic dissection. However, the non-gated CT images showed concerned pictures of isolated left renal artery aneurysm, and further focused CT abdomen pelvis and ultrasound imaging confirmed left renal artery aneurysm measuring 2.9 into 2.1 centimeter, and focused renal imaging did not find imaging characteristics of FMD. Upon discharge, she continued to have vague left flank pain, which she describes as a constant non-radiating pain, which she rates as 5 out of 10. And the patient, however, denies any pain on urination or hematuria. She was referred here by her primary care practitioner for further management of renal artery aneurysm. And the past medical history is significant for hypertension, hyperlipidemia, and diabetes. And she is a former smoker. And in terms of medication, she's on thyroid, toprol, glucophage, and Lipitor. Next slide, please. The pre-procedural assessment started with CT abdomen with IV contrast imaging here. The blue arrow mark shows the large left renal artery aneurysm. Next slide, please. And this is the renal angiography, which demonstrates the large saccular renal artery aneurysm. Next slide, please. The same renal artery angiography demonstrates saccular renal artery aneurysm. Next slide, please. So we decided for a multidisciplinary approach. We involved our vascular colleagues, IR, and we decided for a stent-assisted coiling of renal artery aneurysm. And for this pre-procedural assessment, next slide, please. And we did the sizing.
So maybe Rahul can talk about this a little bit, huh?
Yeah. So we, for these large sort of complex renal aneurysms, our mode of treating them is actually not to bring them and just go ahead and treat them. Is to actually do a planning angiogram to figure out sort of what the best way to treat them is in terms of, do we stent? Do we just do primary coil? Should we put a covered stent? Also, it helps us size it. We can do 3D angiography. And then so then we can also tell the patient, sort of counsel them exactly what will happen to them afterwards in terms of how much kidney we're going to put at risk, and then sort of talk to their referring physician to make sure that's actually okay. We can also talk to the surgeons to see, is a surgical option here, a surgical repair, a better option. So when we did the angiogram, we get about the left renal artery measures about 7+ millimeters. Where we would probably do the stent, land the stent into that upper pole branch, is around 5 or 6 millimeters. We did select the lower pole branch just to do the angiogram. It's actually very difficult to get into it, so trying to get a stent to go there was hard. That covers about the lower, probably 35 to 40% of her kidney. She has a normal kidney function. The right kidney obviously is normal. So 40% on this side is fine. The arteries aren't completely normal. There is on IVUS, there is a little bit of fibrosis in the wall. So again, talking to some of the surgeons, they felt that in trying to do a primary repair to an FMD type vessel is very difficult. The artery kind of falls apart, and you end up actually losing a lot of branches, and it doesn't end necessarily always as well. So their ability to keep more of the kidney than we could isn't really there. We thought about doing a covered stent here, but as you can see, there's actually that very early, well, not very, but early artery going superiorly. I think if we put a covered stent, we'd actually have to drag the covered stent over that vessel, and we would also lose that vessel as well. So our plan is to try and do a wide open cell self-expanding stent to sort of bridge from the main renal artery into that upper branch to protect basically about 60% of the kidney, and then coil through the struts. Here's the 3D angiogram, and again, this just helps us so we can figure out what angle to open everything at, and go from there. So we sort of get these nice pictures. It also helps to show the patients, and the surgeons also like this for planning if they do have to do a surgical repair.
So this is a CT rendering?
So it's basically 3D angiography. So Philips, Siemens, GE, Toshiba, all of the different companies can do this. This just happens to be Philips' product. So basically, as it injects, the machine spins around. It actually can generate a CT scan, and then also we can do sort of these volumetric measurements as well. You can see basically the volume of the aneurysm, which isn't really important for this, but it can be important for other aneurysms in terms of when you're going to pack it and stuff.
Next slide.
This is the last slide.
This is the last slide. So, Ajit, just a question to you. I mean, obviously, this has been discussed. What are the surgical options for all of us out there who don't deal with this commonly for renal aneurysm?
Yeah, no, that's a great question. So the surgical options are pretty invasive. So the problem with this sort of aneurysm is it usually involves the branch points. So it's not like a simple repair where you can remove the aneurysm and do like one anastomosis. You kind of have to manage all those branch points. So in the unlikely event that it doesn't involve the branch points, sometimes you can remove the aneurysm because most time it's saccular. So you just cut out the saccular part and then you do like a patch with like a vein, usually saphenous vein. And that you can actually do leaving the kidney in place. You don't have to take it out or anything like that. The other issue with doing this open is that you have to be, if you're not going to do any sort of renal kind of protection, you need to really sew that anastomosis and clamp and unclamp within 30 minutes so you don't kind of lead to any ischemia of the kidney that would be permanent. With this aneurysm though, you'd have to actually, what I would do is you have to take the kidney out and almost do like a kidney transplant, an auto transplantation. So you have to take it out, put it in some sort of cooling preservation solution, take the aneurysm out, reimplant all the branches, and that, is going to take time. It's going to take more than 30 minutes, but if you have that outside of the body and if the kidney's cold, then you kind of can preserve the function. So at this institution, when we do it, we usually involve our transplant surgeons, Dr. Benvenisti, who's a vascular and transplant surgeon, to do it. But as you can imagine, it's a big surgery. It's very invasive. In someone that has connective tissue disorder, it would be very challenging. And so a lot of patients just, don't agree to that because of the invasiveness.
The other question for Srini, I'm sorry, I'm asking, these are questions that were emailed to me yesterday. Srini, is there any difference in the types of aneurysm as there are in the aorta? Saccular aneurysms may be more prone to issues. Is that the case with the renal? And the second question, I guess, for both you, Rahul, and Ajit, is what do you think is the etiology of this aneurysm?
So I think, getting to your first question, I mean, this one fits, I think, all the criteria that most people would repair this, whether it's endovascular or surgical. It's a little bit bigger than 2 centimeters. Patient is symptomatic, so I think that fits the criteria of why you would want to intervene. Obviously, if it's smaller than 2 centimeters and patient's asymptomatic, you can make an argument for some level of, surveillance without having to do any intervention. I think in terms of rupture, and you can talk to Ajit about this because he's an expert in aneurysm therapy, of course, Rahul as well, is that the more calcified the aneurysm, I think the less likely it's going to rupture within the kidney. We've seen that in the splenic space as well. I think that answers kind of your first question. Second question, most of the time when we've seen these, they've had some level of either a vasculitis, whether it's fibromuscular dysplasia being the most common. That's when we've seen it. And obviously there's aneurysms that are traumatic and so forth. So I think in this one, Rahul is suspecting some level of a connective tissue disorder, right, Rahul?
Yeah. Yeah.
And we did a CT, I'm assuming.
There was a CT scan. It didn't show it as well, but on the IVUS and on some of the angio pictures, which we didn't show, but you can see there's some webbing in the renal artery itself. It's not stenotic, so there's no gradient or anything across any of it, but definitely has some degree of FMD.
Yeah, I think in terms of indication, so typically it used to be 2, but I think more of us kind of 2 to 3 is kind of the range, and this one's around 3 centimeters, so it meets criteria. And then also anyone of childbearing age. So if they're going to be pregnant or if they are pregnant, then we're more aggressive about fixing those because those have a much higher chance of rupturing. Unlike most aneurysms in other parts of the body, this one tends to be saccular more often. And I think FMD is the most common cause. So this is pretty classic presentation.
Right. Just a couple of more questions, I guess, that just came up for the panel, especially Srini, Rahul, and Ajit. Number one is there any determinant of the thrombotic burden present in the aneurysm, which might make things, let's say, not to do it one way or the other? And the second question is, how much kidney volume loss is acceptable in a way? I know if the creatinine function is normal, we can technically live on one kidney. Do you have a cutoff to saying, okay, this much percentage is acceptable versus we have to stop and think about other options if we have a certain higher number? Is there a number? I know it's not a normal common case, so based just purely on experience, I guess.
Yeah, so in terms of the thrombus burden, typically, at least what I've seen, is either the renal aneurysm is completely thrombosed or it's completely open. I've not really seen where it has like partial thrombosis within it. The only time I've seen that is like when there's associated AV fistula. When we close the AV fistula, and then the aneurysm will partially thrombose because there's an aneurysm associated with a fistula. So that really doesn't really come into play, and no one's really studied like, if there's more thrombus in the aneurysm, is there less likely to rupture or not? I don't think we know that answer. In terms of what's acceptable, so one is, I think, first we determine whether we're going to treat this patient or not. Like, does she need treatment? And so I think given her age and the size of the aneurysm and the symptomatology, I think we have to treat her. So then it basically comes down to what do I think I, as an endovascular specialist, can do, and how much would we put at risk, and versus a surgical risk, right? Again, I think as Ajit pointed to, it's not a simple surgery, right? It's a big involved surgery with its own sets of risks. So I think my goal is try to keep it into that like 30 to 40% range of loss of kidney. She'll feel it, right? She'll have some post-embolic pain, but she will not. It shouldn't bump her kidney function at all. Yeah.
Awesome. Srini, anything to add?
No, not really. I think the main thing, though, one thing to consider is that I'm sure Rahul and the team and everybody there, when you discuss this, you're thinking about how are you going to embolize this thing?
That's what I was going to ask.
Right.
Yeah. Do you coil? You've got a couple of options, right? You've got either a stent-assisted coil embolization, which is what we're doing today. You've got primarily covered stent placement, and you've also got primarily coil embolization. I think those are your choices.
Right.
When you think some of the other embolics, I think the problem is you're not going to use glues or liquid embolics. You can't control them, as Rahul knows, very well. And I think with just plain coil embolization alone, you could, but I think you were worried, Rahul, or maybe you can talk about why you guys picked stent-assisted versus just coil embolizing the aneurysm.
Yeah, so I think we could try and do a primary coil embolization, but it is it's not a super wide neck, but it is a relatively wider neck aneurysm, and so I'm concerned that the coil pack as we go will start to prolapse into the artery we're trying to protect. You can do this a different way. You could also try to balloon protect, right? So do a balloon assist to use the balloon to sort of model the thing. But I think if we end up in a situation where it starts to prolapse and then we have to put the stent secondarily, you always run the risk of, as the stent comes around, dragging your stent column up. So I think the easier thing here to do is just put the stent in primarily and then just go through it. Right?
So just
I think-
to be devil's advocate, I know you said the neck. Is that what precludes a plug?
So you can't, you can't, it's not because there's also an outflow vessel, so you'd have to plug all
So you'd have to plug the entire region.
Yeah. So in
Can you put up the angiogram as well on the side? Yeah, there you go.
Yeah, so on the neuro space, there's something called the Webb device, which looks like an Amplatzer plug that's designed to go and fill sort of these aneurysms. But those are really designed for like Barry aneurysms, so basilar tip aneurysms. They're obviously not as big for this, and they're a pain in the ass to land.
And flow diverters would never work here.
So it's been studied. So the flow diverters, in the U.S. there are no flow diverters of appropriate size, which is sort of where we're stuck. I think the biggest one, I think there's one from Stryker now that goes to about 5 millimeters. You can kind of push it, but it won't set.
It won't set. Yeah, that's the thing.
Yeah, you could try to do multiple overlapping stents and try to flow divert it that way, but at that point, then if it doesn't work, you're kind of jailed yourself out from coiling it. So I think the easier thing to do is just put the stent in, leave the safety wire across, and then just coil through. Yeah.
So just a question on natural history of these aneurysms. You said below 2 you monitor. I guess for people out there who find these aneurysms, I mean, first of all, obviously you need to refer to an expert to manage like we did. But the question is, I mean, what is the surveillance? What is the natural history? How quickly do they expand? And what are signs and symptoms that somebody out there who's following a patient needs to watch out for?
Yeah, no, those are all good questions. So, the natural history is, you need to monitor it because these tend to grow. These aren't like our vascular pats that are like in their 60s, 70s. These tend to be younger patients who have a long life expectancy. So the natural history is, if you monitor them, especially if there's no calcium, they tend to grow. So, if I see someone in clinic, depending on how large it is, I'll probably repeat an ultrasound or CAT scan depending on the body habitus and everything else every 6 months to a year.
Wow.
And then if they're childbearing age, so if they're, like I mentioned, that would be someone I would fix on a smaller diameter size. Or if they're symptomatic, of course, if they're having, abdominal or back pain, or, any sort of trauma where I think it's more of a pseudoaneurysm. Those are kind of reasons to repair it more urgently.
Perfect.
But these definitely need surveillance.
Yeah.
Great. So why don't we stop and then we'll deploy the stent and then let because for the sake of time.
I'm just going to go over the setup here. So what we have is a 6 French catapult RDC sheath, which is from Boston Scientific, where we can take off the check flow valve and we put a co-pilot on. Just so
you can get rid of the hemodynamics. We don't need hemodynamics here. Thank you. Sorry about that.
Yeah, it's okay.
There you go.
So we have the co-pilot, and then basically we were able to catheterize the left renal artery. You can see from the angiogram, we sort of have the renal artery there. We did the run, so we already knew the oblique, so we just went straight to that oblique to do the run.
Right, can you show the runs? The one thing I do want to tell the interventionalists out there who do renal work that Dr. Patel went with a renal sheath. This is a sheath guide from Boston Scientific. I'm sure other people make it as well. I'm not promoting one over the other. The bottom line is that I think he felt with an 6 French, it's an 8 French diameter. We can obviously use a stent and are able to inject around it. Quite easy to engage, right?
Yeah, very easy to engage. So it's got the nice shape. It's relatively atraumatic tip. We didn't do the no-touch method. We could do the no-touch method to sort of select this out, but she doesn't really have peripheral vascular disease in that sense, so we weren't super worried. She's got a little spasm, so we did give a little bit of nitro, I think, as we tried to put the stabilizer wire out into that branch that we're going to protect. She got a little spasm, so we just gave some nitro just to make
Is
sure.
stabilizer the wire choice? Are there other choices you could use?
You could use other wires. It's basically a short atraumatic tip and a relatively stiff wire, because we're going to have to deliver the carotid stent over an 014 wire. So typically, obviously, over a filter wire. The tricky part in the carotid, it's pretty straight.
Sure.
Right here, it's going to have to make a little bit of the turns and stuff to get out there. So we want a relatively stiff wire. You don't want it too stiff to basically straighten everything out and really distort the anatomy. But I don't think any of the 014 wires are going to be that stiff where it's going to be that bad.
Got it.
And again, you can see from this angiogram that trying to put a covered stent, which would be obviously a much simpler solution, is there's not enough space, right, to protect that superior vessel and land the stent, because the concern is obviously that the stent will shorten and end up into the aneurysm, and then you got a much bigger problem. So I think this is sort of the easier way to manage this.
And glue, I just want to mention there was a lot of questions on glue that was emailed. Yeah. One is the glue, if you balloon tamponade the proximal ostium and inject with a catheter, that glue can still go everywhere?
It'll go everywhere. The problem is also the balloon. You have to fill the aneurysmal sac with the glue. The glue will stick to the balloon. There are no balloons available. The balloon won't stick to the glue. So now you can some people will do mix, right? So they'll put some coils and then glue or onyx or EVOH the sac to close it, just so you don't have to put so many coils. Again, some of that's also driven by where you are. So obviously in the U.S., liquid embolic is very expensive relative to, say, Asia, India, Europe. Liquid embolic is significantly cheaper. So then, that can kind of drive your decisions about how to treat this. I think here we're just going to just do coils just because it makes it easier and cleaner.
And the choice of stent, open cell versus closed cell?
Yeah, so again, you have to go back to your old school carotid there, right? So, which ones are open cell, which ones are closed cell, and then we picked one that has a relatively wide free cell area, so it just makes it easier to get through. The other thing is, I think even with the bare metal stent, we're going to have to drag it back a little bit to cover that superior branch, but because it's so open cell, I'm not super worried that it's going to occlude the vessel there.
And you chose a tapered stent, or you chose?
Yeah, so I chose a tapered stent. So it's in 10 approximately 8 distally. Again, it's a little bit oversized, but again, we need to again, like any self-expanding stent, we want to oversize it a little bit, and then also we want it to lock in so that as we push the microcatheter through the struts, it's less likely to telescope on us and prolapse into the aneurysm.
Yeah, I think that's a great presentation. So if you look angiographically as well, the neck is essentially not the most favorable. You can actually see the neck size increasing significantly as it's entering the aneurysm rather than having a short neck. So that's why Rahul's idea of doing a primary stenting and then coiling on the side is probably the safest bet in this case, right?
Yeah, for sure. And then, Rahul, I guess if you were going to do a covered stent, if that was, let's say this was a more proximal aneurysm, what stent would you use, and how much seal do you need on either side of the stent?
Yeah, so you want a good, at least, so, it's different than an aorta, right, or an iliac, where you want at least a good centimeter and a half of seal. In a renal, that could be with the aneurysm, it could end up being the whole renal artery. So usually you want probably about 3 to 5 millimeters of good seal, and what I mean by that is like sort of normal vessel to seal into. Usually when we put a covered stent, it tends to be a much more proximal aneurysm. The tricky part, again, is as Ajit knows, is that the ones that are easiest for us to fix are also the easiest ones for them to fix surgically. So we can't really help each other out here. But then you have to run. Then we would have to talk about the risks are a little bit different, right? So then maybe a surgical repair might be better because it requires less follow-up, and we can sort of discuss the durability of the repair, right? Yep. I think with the covered stent, with the coil and stuff, once it's closed, I've not seen them recanalize if you pack them well enough.
So, Srini, a question to you about the choice of coils. There's so many coils to choose from. I know that Rahul's made his choices. Any comments on these coils, advantages, disadvantages?
I mean, I guess you just got to think about how coils work, which Rahul knows very well, and so does Ajit and everybody else. But, you've got fibered and non-fibered coils, right? The non-fibered coils, you get occlusion just from a mechanical advantage is how it works, versus the fibered coils, you get the mechanical occlusion plus you get thrombosis. So I assume in this one, it doesn't really matter because the way I think about it is you're doing a stent-assisted coil embolization, so you really just need mechanical occlusion. The fibered will help because it'll help it thrombose a little bit quicker. So
faster.
I think it could go either way, but I'd love to hear Rahul's take on this.
Yeah, so I think we would do a detachable coil. I think that's first and foremost, because I think trying to blow in the old school nesters and things like that, while we used to do that, it's time consuming and you don't really have a lot of control. And I think that's where we really saw a lot of problems with coil compaction, because you kind of got to a point where you couldn't put any more coils in. So the ones that are available, at least in the U.S., there are a couple different manufacturers. So then you have to think about what they will fit through, so what microcatheter they will go through. And so some of them, even though they'll get you more volume per coil, they go through a high flow microcatheter. So I'm not 100% sure we would be able to get a high flow or even a 2.5 French microcatheter through the struts of the coil. We could probably force it a little bit, and we might be able to, but I don't really want to have to deal with that. So then you're looking at basically a low flow, sort of a 2.1 French microcatheter trying to get the coils through there. So then what do you have? And then, so what we would look at in terms of comparing the coils is which coils are going to give us the most bang for our buck in terms of how much volume and length I can do. Because frankly, the other thing is, again, everyone's super busy and they want to get through these cases relatively quickly. So we don't want to pick short, tiny coils. Otherwise, we'll be here, till the cows come home packing coils, because it is a decent-sized aneurysm. So, what we've chosen here, and again, obviously you want to choose something you're sort of comfortable with using. I wouldn't recommend this being like the first time you've ever put that type of coil in somebody, because you never really know what the idiosyncrasies are, and so you don't want to make this your first practice case. So the one I've chosen is the Boston Scientific and Bold coils. They're nice. They're fibered. They're relatively soft, because again, you don't want super stiff coils. They have a good product line in terms of coil selection sizes and lengths. And so the plan would be, and again, like all aneurysms, we sort of do a framing coil. So we sort of frame it. We call it frame and fill approach, right? So we'll frame it out, but put a bunch of sort of larger coils, and then they have what are called packing coils, which are basically 60 centimeters of metal that are just very, very soft that you can just shove in and just fill in the space.
And how do you deal? Is it a tapered coil, so the stiffness is not going to kick your sheath out as you make the turn?
So it is. So that coil is designed so it's a little bit softer in the front and a little bit stiffer in the back. Even the back part's not stiff enough to really kick us out. The other thing is we can play with it a little bit. We can sort of loop the microcatheter inside the aneurysm so that the forces as we're pushing it through don't really project back onto the.
Well, listen. I guess like you said, it's going to be a little bit. So we're going to get going.
Yep.
So I'm going to give him a rail, and then Karthik will deploy the stent. Go ahead, Flora. Oops, wire came back a little bit. Let me let the wire go. There you go. Okay, good.
Yeah. So.
Go ahead. You can talk him through it.
Yeah. So again. I'll be honest, I haven't deployed a carotid stent in a very long time.
There you go, PK and Guja. Right there.
They're useful for something in the room, so
Learning. I love learning.
So this is a 40 millimeter stent.
Okay.
Wow, that seems really long.
Should be fine now.
Right, yeah. Just a touch.
push the wire a little bit forward.
There you go.
So we'll do a
That's
run.
good.
Yeah,
You want to do a run? Okay.
Yeah, let's do a run just to make sure.
Inject. You have room to go in if you need to.
Yeah, we're going to go in just a touch.
Definitely have room to go in.
Yeah, we're going to go in just a touch. And again, you don't want to get too cute and trying to make it too short, right? That's good.
Spot.
That's good. Deploy.
Just a run. Yeah.
You can
I'm
even
going to bring it back just a little bit, just to cover that little spasm.
There you go.
Correct. I think the good thing is the distal vessels are also decent size. I think the deployment of this oversizing would not be that much of a concern. Of course, it's oversized, which we want to, but the distal vessels caliber is big enough to accommodate the size of the stent they're using. So
For sure.
Push it forward. Yeah, there you go.
And I definitely think giving nitro
There
is
you go, you got
important
it
here
now.
because these vessels are prone to spasm.
So Rahul, just to ask you from one of the audiences, what's the alternative stent you would have used, or Srini, in this case, in case the length was a restriction or the sizing was a restriction? Here you can see the distal vessel caliber is still decent enough to accommodate your tapered stent. But let's say if it wasn't, or the length was too long, what's the other alternative open cell would you recommend, Srini?
Just take a single shot. Just be able to see it.
I mean, I don't have
middle
one.
one.
To be honest with you, Vishal, I'd have to look myself.
Oh, sorry. I'm going to do a run. Sorry.
Yeah.
Yes, I think that's one of those things to, I guess, consider. But here I
Might
think
have
that
to
looks
take care of
good.
the box, but that's okay.
Yeah.
All right.
So again, you can see that that artery is filled, right?
Right.
It's causing a little bit of tension, but I think once we get the mechanism
This
out.
is just, I think, a pseudo potential.
Yeah, exactly. I think
Just
once we get
straightening of the vessel. Yeah.
Yeah. And so again, we've got a good seal. I'm not super worried about the device sliding. We could have maybe got a 30 and just been a little bit cuter, but
No, I think you did the right thing. Absolutely.
we had the 30 just in case.
Let's get the microcatheter for a doctor. So guys, just one question is that, so just to tell everybody, anticoagulations with heparin, ACT is right now 350. We're a little aggressive because obviously it's a live case. I don't think you need to have it that high. So we just went ahead and gave a little bit extra heparin because we're talking and all that stuff. So just, sorry to interrupt, I just wanted everybody to know.
Oh, yeah.
Go ahead, Rich.
No worries. I guess I was just going to ask you, how do you size coils in this case? How are you sizing it to the aneurysm?
Yeah, so the biggest coil they have is a 32 by 60.
I have your.
I think we're going to go maybe one size smaller. Oh, you have the micro?
Yep, it's here.
So if you just pull the wire back a little bit.
Flora? I got it.
But is there a rough rule of thumb you use, Ajit, when you're doing these cases? Or like what's the normal protocol, you would say, or learning?
You got Flora.
Yeah, I think if you're trying to fill in an aneurysm, it's usually obviously a big vessel, and so you're really just going for big coils to kind of minimize how many coils you need, versus like if you're embolizing a hypogastric artery or something like that, then you size
want the wire
it,
forward or
oversize it to the vessel.
Yeah, just forward.
Right, okay.
I have, it's 2 wires in there, right? So
Yeah.
the other wire's coming. There you go. There you go.
It's actually in
just
the
let it go.
aneurysm.
Just let it sail around.
This is so good, Vishal, even you can wire it.
Right.
All right, so
It's so bad.
Wow, there's no case ever has happened in the last 11 years where I have.
Wow, if you blinked, you missed it.
I know, right?
There you go. All right.
it takes a little. You can see it takes a little bit of work.
Yeah.
Can you send the wire? See if it
Send the
goes?
wire forward.
The wire forward.
No,
So what? That's a microcatheter, and what wire are you using?
So it's just nothing super fancy
forward?
here.
Yeah.
It's just
Push forward.
That's
Take
good.
it close.
We're,
yeah.
we're in the aneurysm.
That's beautiful.
Do you have the 3cc medallion here?
Can you guys talk about what microcatheter you're using, Rahul,
Yeah.
and which wire you decided to use?
Yeah, so our selection of microcatheter, we chose a True Select microcatheter from also. I don't want to sound like a shill for Boston Scientific, but
No, it's okay.
What to use? Yeah.
from Boston Scientific, and so that's the
Nice.
yeah.
So you confirmed the position right. Very nice.
Yeah, exactly. So we know we're in the right spot. So we'll take not the 32 by 60, but the one below it. 20,
So, I
22.
mean, for the audience, I mean, it's, as we know, there's multiple companies that use it. It's obviously operator comfort, and, we're not promoting anything. It's just, it's a comfort of the operator. And Dr. Patel has done a lot of these cases, and he feels comfortable with this one.
Yeah, and the other thing is, look, so this one, it's 2.1 French. It's 021 on the inside, so it'll take the coils, but it's got a slightly smaller outer lumen. Or outer diameter, so it makes it a little bit easier to get it through.
So,
Yeah.
so what size is this now?
So this is a
22,
22 by 60.
60.
And maybe you can go with the deployment. Can you show it full
Can we
screen?
zoom in? Yeah.
Yeah, show
So-
him full screen. His
So basically it has
hands.
this orange tip. You're going to bury it.
One second, buddy. Let
One
him
second,
shoot.
Rahul. We just need to zoom in.
Yeah, it's full screen. Zoom in on his hands as he talks. Thank you.
Perfect.
Okay, go ahead.
All right, so we're going to basically marry the the plastic housing to the microcatheter.
Uh-huh.
And then
I
advance.
can do it here. I can
Yep, you do it one hand, yeah.
So we're going to basically take off this orange thing, which is just the safety for packaging.
Introducer, right.
Yeah, and then I'm going to basically feed the coil into the microcatheter here.
So Rahul, for those who are not familiar with detachable coils,
Yep.
the coil is now attached to this, right? At this
Yeah,
stage.
so each of them have a slightly different detachment mechanism. You have sort of the old, let's say, detachable interlocks, which are sort of a passive detachment. Basically, once you were out of the microcatheter, detached. Has its own sets of issues, but it's kind of what we had. Penumbra and Medtronic both have the same sort of ball and pin mechanism. And then, oops, sorry.
Ray, you want to positive?
Yep, and then, so you can see here, it's going in.
Can we focus on the angio, please? Can you
Angio
switch
guys
to the-
now?
Yeah.
Or put both? Ah,
perfect.
thank you.
Yeah, so you can see the coil coming out. It's filling the space. Although it actually now it feels a little undersized. So we'll actually take a 32 by 60.
So why are you saying it's undersized? What does it feel
So
undersized?
you can see it's sort of packed up against one side of the wall. I kind of want it to almost create a ball.
Circumferential.
Yeah, and again, it may, even the 32 by 60 may not. Oh, there we go. So
That's a little better, right? Yeah. So for those at home, you can see what Dr. Patel was talking about with the stent. You can see how the stent is preventing the coil from prolapsing, which is what he was worried about. Now he's going to detach. Show his hands again, guys.
yeah, so I'm going to try to bring it into frame. So
Yep.
if you can
Yes.
see, there's two white markers here. And so what you do is, it's very simple. You just break it and you pull it a little bit. And so what's going on is there's this really, I don't know if you guys can see
Yes,
it.
I can see it.
Yeah.
But there's a very, very thin wire
Yes,
that
you can
connects.
see
So
it.
that thin wire goes all the way through and through a little hook. And so that actually basically, sorry, it's not out all the way. Now it's attached.
So now when you detach, you don't pull the microcatheter, you pull that little wire.
Yep, that's it. And then we'll just keep going.
All right. So we'll do one more of the large. We'll do one more of the large ones, and Shalini has a presentation. But while we're doing this, any comments, Srini, and everyone?
Yeah, I think two things. Really important thing was, the microcatheter Rahul picked is a relatively flexible one, and I think you have to realize that not all the
Just
microcatheters
give
are
a present in a second.
flexible. Some are a little bit stiffer, and you obviously want something flexible that'll kind of take the shape of the aneurysm and go
You
around
do
the
anything
curve.
about aneurysms? Nothing? Oh.
I think the second thing in terms of coil deployments, there's passive, like he talked about, where once it comes out of the catheter, it releases. There's mechanical, where you're using kind of a device that you attach at the end, and there's also current, electrical, where it has a current that detaches. So, and then in terms of the framing or the anchoring coil, the reason he was worried at first when he was deploying this coil is that this really comes from the neurospace, right? You need a coil that's going to frame the entire aneurysm so that you kind of are filling the entire wall and kind of hugging the wall, and then at that point you're packing it in.
Another one, guys?
So I think packing density is something that's going to be a key discussion point in your presentation.
I was just going to ask you, how do you know when you're done? Exactly.
Yeah, so there's good data from the neuro space, which and some from the peripheral space. Obviously, neuro has numbers that we would never be able to, because we just don't see as many aneurysms. as they do, right?
Can we see the angiogram next? Yes, please.
So we
Yeah,
look at
perfect.
about, we want to get about 27% coverage of the aneurysm, and what that means is,
And how do you assess 27?
yeah, so one is, I actually
Well, this
know the volume of each coil, right? So it's not the primary wind, or it's not the secondary wind, sorry, which is that 32 number. It's actually the diameter of the metal itself. So we want that metal to sort of fill the space as best we can. So we're looking for about 27% as sort of the bare minimum of how much we put in there. On the 3D, we actually did measure the volume just for sort of academic purposes to see exactly what the volume was. And so we have sort of a general idea of how much length of coil we need to fill this. Now, the fibers are interesting. So some people will argue that the fibers don't matter. But I think here, because we sort of covered some of it, and you can see it sort of filling very nicely. We've covered some of it, and we're going to protect it. And the stent, even though it's sort of open cell, will act a little bit as a flow diverter. You could see even after we put the stent, there was a definite change in the flow dynamics into the aneurysm a little bit. So yeah, so that'll also help. But the one thing we don't want to have to do is try to get into the stent twice, right? So we're going to try to make this.
So I have one other question for you. Is there any chance that a collateral can fill the retrograde branch and pressurize the aneurysm?
Not out here. I have not seen sort of a branched filling of the renal artery. Now,
is it because they're end arteries? And
yeah, exactly. They're end arteries. So now,
you ever take a picture just to see if?
No, I don't think you're ready yet.
Yeah,
right?
It's not going to be closed. It's going to take a lot of coils.
Yeah, I know. That's good.
PK, I think Rahul made a really good point here is that you're doing a stent-assisted coil embolization, so having a fibered coil where you're going to, because you want thrombosis, right? That's the ultimate goal here.
That's the ultimate.
And so you really, a fibered coil would make the most sense in this case. Rahul.
So the question is, so now you're coiling off this aneurysm. As this thrombosis, you're going to have delayed thrombosis of the distal branch. It's not going to be quite acute, I don't think, right? This has to thrombose first, because currently I'm sure there's still a little flow in that distal branch. So I guess the point of the question is, when does she start getting pain?
Yeah, that's a good question. I'll be honest. Once it starts to thrombose, that artery is going to shut. So
okay, that's when she'll get it.
Yeah, it'll be pretty soon.
And in terms of pain management,
sometimes you can see it by the end of the case.
One more, right?
One more.
A lot more.
Yeah.
So it can happen pretty quickly, actually.
Yeah.
Okay.
Yeah. And ideally, we'd like to see it thrombose before the end of the procedure, right?
Ideally, yeah. Well, that's why I'm just going to let my nurses know, because they're going to have to be on top of the fentanyl.
Yeah, honestly, it's like this aching pain. It's not like the severe like 10 out of 10 pain.
Okay.
So they tolerate it pretty well. And again, you just sort of tell them beforehand so they know to expect it. And I usually tell them it's going to be worse than it probably is going to be. Again, it's just sort of
just to prefer them. Yeah, I don't blame you.
Right.
The other question is there any chance of erosion of these coils?
I have not seen that. They're very soft. So actually, let me rephrase that. I have, but not in this.
In a pseudoaneurysm, probably.
Yeah, in
right?
a pseudoaneurysm, when we've coiled varices, we've seen them erode into the GI tract. I'm sure there's a case report somewhere of someone finding this in someone's ureter.
That's why I asked.
Yeah, but I personally have not seen that. So
it's like what Will said, PK. It's definitely more common with a pseudoaneurysm. We've seen erosion. You've seen kind of that type of thing. But I think the other thing you got to be careful of is because you're putting in so much, metallic alloy type of stuff. You always want to make sure you think about infection, right? You want to avoid infection as much as possible, and that's why sterile techniques, pre-embolization antibiotics, making sure the patient.
1,000 more.
Well, those are all kind of key points to find.
Just to tell you what's going on. So it's a little bit harder to push those 32 by 60s, which probably means we're getting towards the end of that size coil. I'm just going to flush this a little bit.
Yeah, that was my next question to ask is when do you resize, so to say, to a smaller size coils?
What we're going to do is actually go to that packing coil, which is basically unshaped coil, so it's just going to fill the space. So then it used to be that we would just sort of do I call it the Russian nesting doll, right? We would just go 32, then 22, then just keep going down sizes. Here The packing coils here are actually unfibered, but they're a little bit more stiff in metal, and they're very, very soft. So you can just see it's just...
What's the size on these packing coils? So how did they come in?
They're basically by length.
Looks like they're prolapsing a little there, huh?
Yeah, so I'm going to pull this back. I'm going to put this back, and then
And
just...
I think the key thing, Vishal, is that it's really a visual.
Should we go to
thing.
another
It's
view?
simple.
Oh, no.
No, I think we're good.
Oh, you're good, right?
Look, I think when you look at how much coil
What
is
is
in
one
the
up there?
stent,
Is that in the aneurysm too?
really
Right.
trying to
So here's
Oh, yeah, I see it.
really get in a
Wow,
long
the aneurysm
coil,
is huge.
a lot of
Another
metal
one.
into
Huge.
this thing. I think. So it's really an
Definitely.
experience that comes with time, and I think Rahul is making this look easy, but this is a very complex. And he made it look like it's no big deal, but this is a very. And one of the key things, though, you notice after he puts in 1 or 2 coils, you notice he's always flushing and aspirating.
Yeah, I was going to say that. Yeah.
The catheter gets beat up a little bit. You need to make sure that it's has good lubrication and has that lubricity.
Well, that's a great point, Srini, because you don't want to keep trying to rewire this stent now. If you lose position because whatever your catheter gets thrombosed, it becomes a real pain in the neck for everyone to get back in. So
Yeah, especially with the coils already there.
exactly.
Yeah.
Good point.
Where exactly is your microcatheter? Are you burying it
Go to another-
deep in the aneurysm, or it's so hard to tell?
Completely deep in
It's
the
hard to tell.
aneurysm.
We can try to go...
No, I can't tell.
It's hard to tell. So, some of these microcatheters have 2 markers on it, so you can kind of tell. This one does not, unfortunately, which I don't think we're
Right,
ever going to
can't
get
tell.
2 markers on this one. But I kind of know based on... That's kind of also why I looped it, so that if it starts to prolapse, I can feel it.
Well, yeah, it did slightly prolapse, and Rahul and I saw it, and then he just kind of pushed it back in. And so this way there was no issue. And
Yeah, and you can see, I'm not really doing much here, and you can see it's like very on the bottom of
On
the
the bottom,
aneurysm.
it's just filling.
Yeah, it's just filling,
it up.
right? So it's just
I think
packing
it's a
up.
great control of the catheter and, just trying to be embedded as much as possible. Like he talked about, initial looping of the catheter was important to give you that extra length. In
You want
case
one
it
more?
starts to kick back, you're still actually in the true saccular cavity and then trying to put coil as much as possible rather than struggling and just
cranial
rewiring or
overflow.
re-accessing the whole thing.
Yeah.
nope.
So that's a
Yeah,
great
and once you
control.
get so much metal,
Go ahead, Rahul.
And then Rahul, is it usually that easy to pop through the struts, or can it be challenging with these?
It can be, and again, that goes to sort of the selection of the stent, right? So
Right.
you could theoretically do this with a balloon expandable stent, and we've done it with sort of the balloon expandable coronary stents. The problem here, obviously, is the length, right? And the size discrepancy between what's available in the stents and the artery itself. So again, I don't know why I'm flooring it for this. So yeah.
And I think that's Vishal. I think that's one of the hard questions you're asking: which stents to use. You really need an open cell stent. You want self-expand. You need to look at the actual package inserts. They talk about the width and the diameter, the interstices and the struts, and so it really just comes down to picking one where you have enough space to get the microcatheter choice through.
Now you're looking
Yeah.
like the top spot is weird, huh?
Yeah,
I
so
think
again,
I agree with you, yeah.
yes, I don't necessarily need.
Yeah, I don't think you need it either.
Yeah.
I think you'll just close that.
It started to look pretty dense, so I think...
Yeah.
Well, Rahul and I are talking about that single coil that's kind of on top.
hanging around there between 12 and 3.
Yeah, it looks like somebody's ear with earwax, and you could see that. But Rahul is saying is that it doesn't really matter because if this thrombosis is just going to extend over there.
Yeah, and then you'll get some, I think on the neuro side again, because they have sort of the best data in terms of follow-up and everything. They'll see sort of the aneurysm remodel,
Right.
and come down and stuff.
In a CAT scan.
So that's actually a good point too. Is actually how you're going to follow this. So
Right.
obviously a CAT scan's not going to work.
Right.
So
You're going to have a lot of shadow drop off.
yeah,
right?
a lot of shadow drop off. It's going to be super dense with metals. So what we tend to do is to do MRI follow-up.
Oh wow.
Because you can see through this metal with the
So now it's the top
Yeah, so
part,
it's actually
top
filling. Yeah,
part is
it's-
filling up.
the one good thing about these sort of packing coils that
Finds
they
the spaces.
yeah, some people call it like liquid metal. It just kind of finds the space. We'll take another one. Yeah.
The least resistance.
Yeah.
I think the key thing too is if you watch Rahul's hands is that as you're deploying the coil, sometimes you'll have resistance and you may need to pull the catheter back a millimeter to allow the coil to kind of come out and start forming its shape. It's one thing to consider. And so it's a very there's a tactile feeling.
But Srini, I think on that, I think again, Rahul is making it look so easy. But if a person who hasn't done a lot of these can actually pull the catheter out by mistake when they're doing that.
Yeah.
Yeah.
And that's why I think that whole looped it around there, to
Another coil.
No,
Yeah, just
another
another one. Yeah.
Let's get another one.
So I was always taught that you don't want to see any gaps through the coil mass. Is that still kind of how you judge it in part,
So
or is it
that
more
is
by
that is the ideal, and sometimes there's also the practicality of it, right? Like at some
Right.
point, we may like some of those lower gaps, we may not be able to get anything there, right? So
So you're just going until
Yeah.
you basically are getting a lot of resistance with even the smaller coils, right?
yeah,
Is that
exactly.
the-
Yeah, yeah.
And as far as
at those interstices, yeah. Go ahead.
No, I'm sorry to interrupt. I'm just curious about antiplatelet therapy. You've got to do you treat it like a carotid stent now because you've got a stent in the or a renal stent, I'm saying, and not worry about the coil. You're more worried about the stent now, right? Rather than the coil.
So I probably would, at
Yep.
least for the short term. you
Sure,
know.
me too. Yeah.
Yeah, I think she doesn't have any reason not to
No.
to be on it. So I'm actually we're gonna probably do another one.
Oh, like dense.
That's great.
Yeah, and you can see it's becoming a little bit harder to introduce these coils too, right, Rahul?
Yeah, you can feel it like it's
Right.
almost like a grinding feeling as the coils are coming out, and that's just the coils packing up against each other.
And also interesting, if you look at it as a clock and you look at 11 o'clock on the aneurysm, you see it's now butting against the stent. So I think, again, showing what Dr. Patel was talking about in terms of prolapsing, that area right there, you can really see that the coils are now against the stent and would have likely prolapsed if we didn't have a stent-assisted coil here.
No, definitely. That's a great demonstration of angiographic evidence. Of course, the tactile feel and the feedback from Rahul of how to get the stents in. Just slow, easy, but at the same time maintaining your getting all the stents in. The coils in there to make sure we get the adequate results. So
You can see it's starting to fill the bottom.
Yeah, fill the bottom.
Yeah.
Just
Yeah.
filled up the
So
bottom.
it's amazing because you can see like each area of this aneurysm is starting to fill in with these smaller coils, and I think the idea again, like I'm curious to see when you would say we're done, because
It's still a little too easy to pull. And again, we're
Just for the
going.
comfort
No,
level.
no, it's fine.
Yeah. And the
Yeah.
thing is, we do this. We said 27%. That's sort of our minimum. I think obviously if we can get more, that's better. Obviously, Boston would love it if we put more coils, but I always joke with that. But,
So Rahul,
I think they're happy already.
just a quick question: did you have to reposition your catheter right now because it's getting dense? Did you have to pull it back a touch?
Not yet. And again, that's sort of why I looped it up like that. Is that I have a lot of leeway to pull it back.
Right.
So I can, if I have to reposition or move it, I can. I did a little bit when it looked like the coil pack was really pushing up against the stent there, so I pulled it
Stent
back a
part.
little bit. Yeah, I
Yeah,
pulled it
because-
back then, but now this is fine.
Yeah, I guess you're right. That's another sign to say that you still have enough space. If the catheter is not really getting kicked back, and you're still in the same
Yeah.
position.
You can see, like, as I'm pushing the coil, which it wasn't doing before, you kind of get this
Yeah,
little wave into it.
Yeah.
Which is fine, right? Like it's just you can
There
see
you
now it's
go.
starting to.
There you
Yeah, you
go.
can see the kink now. Yeah.
Well, I also think that this is a true dimensional view of a three-dimensional structure.
Yeah.
It's very hard, even though Rahul and I tried to go to different views, very difficult to see where we are. So one more probably, right? Definitely a couple
Yeah,
more.
a couple more, at least
Yep,
one or two
at
more.
least three more.
I mean, this is the other thing, right? So like, as much as I would love to like reposition it to get it into that spot, I have no idea how I would get it there through all
Because
this.
you can't see it.
I can't see it, and
Amazing.
So
Yeah, and I think it becomes an issue if you have to, let's say, push it back in now because it's packed in with the coils. It becomes harder to go back in, so you don't want
Right.
to lose all your area that you've gained initially, and then
Exactly.
keep it right there.
yeah,
So,
yeah. So as long as it's still easy to push, we're just going to keep
Correct.
pushing. I mean, it's kind of boring to watch me push coils, but
No, I think the discussion is great. That's why we wanted to do the discussion is great.
I'm gonna.
Do you anytime in the middle do a angiographic test just to see how it's doing, or it doesn't matter? It doesn't change your strategy or plan or anything whatsoever. Like we haven't done a test shot, so I'm just trying to get: is it
Yeah.
required, or you just keep doing it till the end?
I think we'll probably just do it at the end.
Okay.
I agree.
I think it's a little different, like when you're doing with like a splenic artery aneurysm or mesenteric artery aneurysm. It's a little bit different here. I think there's really I don't know what I would see.
benefit.
Yeah, I don't know what I would see on there that would
aneurysm.
change what I would do.
Okay.
So
I'm just gonna-
is it acceptable to leave it even if you see flow
think that
through the
coil's outside.
aneurysm? Because sometimes when we do these hypogastric
Don't you think it's in
aneurysm
the top-
embolizations,
Oh, no, it's not. It's perfect. Yep,
we still see
perfect.
flow through
Yeah,
the
you're right.
coil
I
mass.
see it. Yeah.
So in this case, would
Is
you
the
still
wire
be
too
okay
far,
with
you
that?
think?
That's okay. We're good.
Yeah, we're good there.
Yeah.
I think it's-
So
go ahead.
go ahead, Srini. Sorry.
No, I was just going to say, I mean, I think, look, at this point, there's always that thing when we're coiling aneurysms, is it how much of it have we done enough? And I think if it's an easy to get to location or an easy to get to aneurysm, then you can make the argument that, all right, well, it's pretty dense, it's sluggish flow, it's probably going to thrombose. But the problem is if it doesn't, especially in this case, you're not going to get back into this.
It's
right.
Yeah.
So you really want to make. So I think in this case, Ajit, I would say pack it until you can't get any more coils in there.
Starting to get into that space, right?
Now I see it. Yep, now you got it.
Yeah, now.
Now you see it's now filling in that middle space that we were talking about. So I think this coil is it's actually quite amazing that it's actually the way it's going, and it's very important. You can see that he's filled out from distal to what is it called, superficial all the way to the middle, which is kind of interesting.
Raul, what do you think about that coil going at 3 o'clock? Sorry.
It shows you how soft these
No, that's the wire, Vishal. That's the wire.
Oh, that's the wire.
Yeah, that's the wire. So I kept the wire there just to give us a sense of stability, because if my microcatheter did pop out, I could still have the access through the stent. Also if we have to potentially balloon the stent a little bit, I didn't want to lose it.
Nice.
Yeah.
No, that's a very good thought process.
That Rahul made is that because you have such a dense coil mass, the coil mass can narrow your self-expanding stent a little bit, because as we know, they don't have that much force, and so you may have to balloon this at the very end here.
Well, we're planning on IVUSing it at the end just to make sure there's no indentation. So that's one thing we had already planned. So we've got the IVUS team here, so we're going to IVUS it, and especially that proximal area, which I think is a pseudo lesion. Make sure it's not anything else, as we were doing all this stuff. So I think while Rahul's here and everybody's here, we'll just do a quick IVUS at the end to see.
I think one important thing to note is the guide stability. We haven't seen the guide pop in, pop out in this case at all. I mean, the stability is phenomenal, which I think also is an important factor in choosing this. So is this your to-go guide for any renal intervention, Rahul, or is it just because of the aneurysm?
It is. Well, it depends on what I'm going to do, right? So I think for like straightforward, like renal osteal stenting, I kind of prefer just a regular 6 French actual guide catheter, like an RDC. Sure. Or we'll do it from I think a lot of us have moved to a radial approach for these. So we'll use them, there's a 100 centimeter FR4 guide, I think from, I want to say Medtronic.
Yeah. It is, I think it's Medtronic.
Yeah, so that one's good. There used to be a JR4 one that Boston used to make that was 110, but they stopped selling it. It was like a special order, and I guess we were the only ones ordering it.
No.
Yeah.
No, I think that's a good approach, because I know you guys do a lot of renal stenting through the left radial as well.
Yeah.
Because of the takeoff. So in this case, getting a groin access was also an interesting proposition.
Well, I think here, just because of the stability he needed, I think it makes a lot of sense.
Take one more.
Yeah, one more, guys? Yeah, I asked for 2 more.
Is this what you do, Rahul, for splenic artery aneurysms in terms of your support system, or do you do something different?
Again, I think it depends. So a splenic is a little bit harder to get, depending on the tortuosity of the celiac. It's a little bit harder to get into from the groin. Now, look, we could do it. It's definitely doable. But the approach is a little bit different, because the splenic artery aneurysm, they tend to be more sort of the main trunk of the splenic artery, and so I can actually just close the whole main trunk, or not the whole, but across the splenic artery itself. And into the aneurysm. So it's, so basically close the outflow, close the aneurysm, and close the inflow, and then the splenic artery will fill distal via collateral. So you don't really get like a splenic infarct with it.
Right.
So I don't necessarily need to put like a stent-assisted coiling and stuff. I mean, the main reason for going from the groin is that I have to we were going to put a carotid stent.
Right.
To put a 6 French sheath, especially the one that I chose, we had to put a 6 French sheath. There we go, starting to fill that space. 6 French sheath into the wrist, into the left wrist. The R2P sheath is, even though it's 6.
Nope. Prolapse. Yep. Yeah. There you go.
Yeah. So we just go. Kind of. Let's see.
So now you can see that at home. You can see it prolapsing back.
No, I think we're actually done.
We're done.
Oh, it's still gonna.
I think a key thing too, if you notice during the case, Rahul was doing some oblique imaging. Like PK said, it's a 2D image we're really looking at, and you have a 3D aneurysm, right? A 3D shaped aneurysm in a 3D space, and so doing some oblique imaging to see if you filled the kind of the sac itself, how much packing density you have, and if you notice, he was doing some oblique imaging during the case.
Yeah, so the one good thing is because we have the sheath and the guide and the wire and everything across, I don't have to use my microcatheter to do my run.
So again, for
Wow.
we can do a non-coronary here just to see a non-DSA. I'm saying just to see the filling.
Already, it looks fantastic. I mean, look at you have such
We still have distal filling of that artery, but the
entire nephrogram for the most part,
Coronary.
Yeah, still there.
Yeah.
Coronary.
Yeah, but there's no real filling of the aneurysm, at least that I can see. There's clearly some leakage around, and it may end up being that vessel may not be lost, right? Is that it kind of leaks around and it may just close very, very late. And that's okay, but I don't really see any contrast
In the aneurysm.
because you kind of see a little bit going there.
Underneath part,
underneath part, but I think that'll seal. The other thing is, this is protective of what we're worried about, right? We're worried about rupture, and I think this will protect her from a rupture.
Correct.
So
From the growth.
Yeah, from the growth and the rupture. So I think also we're running out of we can't really put any more coils in, so we're kind of done here.
And, can you comment on when you would use a gel foam slurry?
That's what I was going to ask you. Yeah.
Yeah, the problem with the gel foams, we could try to use Onyx. The problem with both of those is that the gel foam's uncontrollable, right? So and it's also temporary, so I don't think it's going to work. Although once it's thrombosis, it's going to close. I think there's so much metal in there. Like we don't have to do the run, but you can see even in the different obliques, it's not like.
I mean, look at the packing density. I mean, this is incredible. I mean, it's incredible packing.
So, I mean, there's a little bit proximally that we didn't get. I mean, we could try and pull this back.
We could try to pull back. You wanna?
Yeah.
Yeah, there's a couple. Let's pull this back and try one more coil, guys. If we can get it in there, it'll be nice. Because I'm just worried about. I mean, the flow is good, but I'm just worried whether.
Are we in a different setting?
No, we'll put it on coronary.
Yeah, on coronary.
Coronary.
Yeah, you're good.
Can you give me a shorter one? Let's try 30. Yeah.
And in reality, I think at this point, this will thrombo for sure.
Yeah, the aneurysm will. Yeah.
We'll try to put one more in.
We'll try to put one more. I pulled it back a little bit to see if it finds a different space. We can also try to put the wire and see if we get lucky and it goes. Actually, I don't want to lose it because I think the wire's going to kick me out.
Kick you out, yeah. So I think again the advantage of the detachable coil here.
All right, 15's fine.
Yep. As we're going forward, if this starts to kick back, you don't have to deploy the coil. You can just pull the whole system out.
Yeah.
Which is nice with which I think with the older coils, especially the cardiologists in the group, a lot of them will be using older coils. Yeah. I think it's important to get educated on these coils, and so I think
it's pretty. This coil I like is because I call it relatively idiot-proof. Is that the push wire is actually made out of nitinol, so you don't have to worry about kicking it and getting premature deployment or detachment, which is always a worrisome thing. So here we're going to put this last. This one's much shorter. I'm just trying to see how it behaves. So I don't. Oh, all right, that's going. Can I get another 60?
Yeah, I think we should.
All right.
No, hold on.
No, that's good.
That's good.
That's our coil.
Yeah, I think we can put a few more here. Yeah. Try to get 2 more at least. Because I think when Rahul pulled back, he got into an area of less resistance.
Yeah.
So
I'm just worried about that.
Is there a role for non-detachable coils at this point? Is it just cost, or when would you use that?
So that's a good point. So you could use if you're trying to be cost conscious, and at Sinai we're not always cost conscious, but you could do the frame coils, right, and then sort of mix and match, right? So put cheaper non-detachable or passive detachable coils to sort of fill some of the space, and then go back sort of using the more expensive coils to finish, right? As like a finishing coil, and so you could definitely do that. It's just a little easier here, I think, just to.
Sure. Yeah, keeping life simple.
Yeah.
Oh, if these go smooth, I think that's what I'm saying. He's filling in that proximal area. Now you're straight.
Okay. See, now you can see the catheter.
Yeah. Just doing a quick ACT.
Yeah, sure.
Okay.
Let's see.
So again, I mean, live cases are one thing. Always got to watch the ACT. All those things. Watch your distal wire, Karthik. Just pull the other wire back.
So now we popped out.
Yeah. There you go. Thank you, Karthik.
Yeah,
I'm going to try and ride the coil in, but I don't think it's going to.
No, I think we're done, huh?
Yeah, I think it's not going to.
Yeah, this one is it.
Yeah.
So now the body's telling us, I am done, probably.
Yeah, so we can. So we can just pull this
That's
out.
a good demonstration.
We'll just now take a picture.
As you just said, idiot proof, right?
Yeah,
That's
exactly.
a good demonstration of.
You can
pull it out whenever you want.
Yeah.
We'll take one last shot, and then we'll do a quick IVUS if you're happy. Okay, to see the flow is
starting to slow
it's
down.
definitely slowing down.
Yeah.
So we're going to do a quick IVUS now, and then we'll sign off here. Any comments as we do a quick IVUS? You go, Rahul.
No, I think
Yeah,
it's a great demonstration, and you guys made it look easy. Rahul, you made it look very easy. I think.
Yeah, I second that. You made it look very easy. These cases can be really challenging to get into the stent, to pack it well.
I mean, I think a lot of it is just the pre-planning, right? Just to
Switch to the IVUS, guys, for me, Flora. So for everybody at home, we're doing the IVUS here, nothing to do with the coil. We want to look at the stent expansion, and we want to look at that proximal area right before the stent that Rahul and I were talking about earlier on, just to make sure. And, you know, I think that these are the things that we're going to see as we come out of the guide here. Yep. A little bias going on. There it goes. Okay, good. In the stent. Now we need to go past the coil now. And this is the area which Srini was talking about, the ballooning. No, it looks pretty good.
It looks well opposed, no malapposition.
All right, ready to record, guys? Record. So we're really looking for any indentation of the stent, any prolapse of coils here. Nothing that we see within the lumen. Good flow. And then there it is, just outside the stent. We go forward. Ah, there it is. Yeah, it looks like something going on there. That may be bias. I mean, what do you think, Rahul?
You can pull the soft part a little bit.
I think
So we're going to take the IVUS out, pull the soft part of the wire, and take a shot.
Can someone hold that guidance? Sir?
Yeah, right at the edge.
Yeah, it just looks like
It's
that's
just
not
a
a,
wire bias.
so the IVUS team, that's not a dissection, right?
What do you say?
No,
I
I'm
mean,
just asking.
possibly we had a little bit of spasm,
That's what I think too.
Yeah.
Maybe pull the soft part of the wire back. Yeah, keep coming. There you go.
So
Now let's see.
No,
Yep.
let's.
Now we'll take a picture.
still in the stent, so it can be dissection. See.
Yeah.
Can we see the
So-
angiogram image? I want to see
An
a.
angiogram would help here.
Right.
Yeah, we're gonna go ahead and get the.
1 second. We don't. Yeah, perfect. That's better. We 3 all 3. Yes.
You think it is a dissection? Okay.
Yeah, because it's right in that bend.
Cindy?
You want a DSA?
No.
Yeah.
Yeah.
No. It's. I don't know if it's a dissection.
But I think we're gonna have to. I think we have to
Maybe
extend the stent back.
Yep. So get us a renal stent here, guys.
It could just be a kink, right?
Correct.
You want to go with a better wire? Or you okay
You
with
wanna go
this?
I think if you saw the initial angiogram, there was like a turn right there, which probably is just exaggerated because of the stent. So I think it's just probably more of a kink as well. But
Looks
Give
like
us
to
a
be on the
run-through
safer
wire.
side,
run through won't be enough support.
no.
There you go. No
Yeah.
problem. Now
No
give us a
problem.
renal stent. What's the size there, guys? What's the size when?
2.
No.
There you go. It's starting to
There
strain.
you go.
Yeah, because
Good.
it already
Perfect.
strains out with the wire.
Yeah, we're just gonna put a stent. What is the size of that renal?
6.5.
6'5"?
Well, it's a 10 millimeter
No,
stent.
it's a 10 millimeter. Yeah, it's a 10 millimeter
So
distally.
what would you like to do, you think, then?
I think we get away with a 7.
7. Okay, get us a 7.0.
7
7.0
shot.
renal stent Hercules.
Yeah.
Herculing. Yeah.
Yeah, 'cause we
Yeah,
can
it's a
always
6-0. Yeah, it's a 6'2", 6.
I know, but it's going into a,
Yes. 8-0. The 6.
Or whatever.
Measure that vessel.
yeah, what do you have, 6'5"?
6'6".
Yes,
7.0 should be good.
Yeah.
7.0 should be good.
We don't have a 7.0. We have a 6, we
What
got
do you guys
6,
I
normally
think a
use?
6 would be okay, because the vessel is 6. It's not gonna
6'5". We have a 6'5".
We have a 6'5".
That's plenty.
Yeah, we have a 6.
And then get us a 7.0 post-bill balloon.
Approximately.
Wire track. 7.0 wire track.
Yeah.
Yeah.
All right.
So you
So
use
the-
a balloon expandable stent?
Yeah,
Yeah.
I think it's just easier here.
So question here, I want to, what do you think caused that?
It's probably ending right in the bend of the vessel,
Yeah,
and I think it's just kinking. I don't think it's a dissection. It's just the kink of the metal and the bend together.
It's just the exaggerated turn.
Yeah,
of
the
the
exaggerated turn of the vessel.
But the problem is, I don't think we can leave it though. That's
No,
correct.
no.
Yeah.
I think
Well,
all
you
of us
see it
agree.
you see it in carotid stents too sometime, right? Like
Yeah.
there's like a tortuous
There's a
carotid and
tortuosity,
it
yeah.
kind of propagates the tortuosity past the stent. So I
But
think that's
here,
what
but
happened
the only difference here is I guess we don't IVUS carotids enough. We leave them. But in
Yeah.
this case, I think with the flow and the fact that we're going to lose part of the kidney, it's probably better to just stent it at this stage and leave it and walk away with knowing that you've taken care of the problem. But it also shows the utility of IVUS. I think we need to utilize it a little bit more to kind of see what's happening. I think it's very important.
I wonder if just straightening out of that distal segment of artery kind of just exaggerated that tortuosity.
Yeah.
Created.
There you go. Perfect.
And the other thing is this.
you know.
Can we
This is
just
the right-
do a
right
run
thing
real
to
I
quick?
will,
do.
buddy.
Yeah.
Yep, 1 second.
I just want to make sure we
Just go negative. Negative. Don't go positive.
Yeah.
Ready, Sinai? Sorry.
That's a
Good.
good spot.
Yeah, we want to come back a little. I think we can come back a little.
Yeah,
Come
slightly.
back a
Yeah.
little
Mhm.
bit.
You have plenty of overlap.
And you don't want to slide through the stents too, right? I think
You don't
we
want to
will
miss it.
fall.
Yeah.
No, we're not gonna.
No,
we're
we're
not
not gonna miss
We're not
it.
gonna miss it. Yep.
I think that's good.
Go up high pressure. Get us a 7-0 Vitrac. Keep going. Keep going high.
Wow.
12. 14. Okay, Sinai. Yep, perfect. Thank you guys. Down. Go up again. Got a 7-0. What do you have?
You want to go in a little bit, Rahul?
Yeah. Go.
Armada.
Yeah.
That's good.
720. All right, give me the 720. Armada won't go though.
Armada will
We
not
had a
go.
wire
You have
track,
to give
no?
me an overnight.
We don't
You have
have
an
it as
overnight.
always, as you know, Mount Sinai
Overnight
doesn't have
740 is okay too.
Done?
Yeah, I mean, do you have like a Sterling? Like a
No, unfortunately. Do we have a 7-0? We have
No, we have an overnight ultraverse.
We have
we'll
a- no,
have
but-
it, or something like
short though, right?
We don't have length though with ultraverse.
that. Oh, 40 is
Well,
okay.
do you want to
no problem.
IVUS
Yeah,
it?
Yeah, we're gonna IVUS it. Yep, Sinai. No, actually, we'll IVUS it. Why
Because if it
bother?
looks good, you might be able to leave it alone.
No, I think it'll be malopposed.
Yeah.
Yeah.
It's a 10-0.
All right, can you run down to our radiology department and just grab a 7-0-15, somebody? It's 7-0-15. Just in
We don't have a
case.
15. We have a 7-0-20.
7-0-20 is fine. Yep.
What do you guys use to balloon your carotids?
Uh,
Because you're not really going 7.
No,
You
we
don't
don't go to 7.
We
Yeah.
don't post the carotid so most of the time. So.
Yeah. 520.
Yeah.
440. Yeah. So, I mean, that's again, like the PK talked about, use of IVUS was essential in this case. One, mainly for the stent sizing and knowing any residual stenosis or dissection which might have happened.
Well, I also think it shows the utility of pulling the wire back, right? 'Cause
Yeah.
Yeah.
the wire can keep the vessel
Sure,
straight.
brother.
You might not detect it until you remove the wire, especially if it's stiff.
And I think that's a very important point, yes.
And it wasn't a very large diameter wire too, so it shows you how that.
So there we go. So it's well opposed. I think we're done. I mean, I'm going to balloon it offline.
We're done.
Just for my own
beautiful.
sleeping.
So record it, sorry.
Yeah, go for it, yeah. 1 second.
Yeah, I think it looks
Ready? A
good.
little further distal. Let's go
at that.
distal. Okay, let's record. Slowly. Okay, this is the transition zone.
Double tip.
Right there.
That's good.
Two
Oh, it
sides,
looks
yeah.
pretty good. So what I'm going to do is I'm going to balloon it with a 7 offline, since it's obviously Dr. Patel's working and then Dr. Rao's working as well. So I really appreciate it.
You want to do a final run? Just to
Yep, we're gonna do a final run here. Notice, Ajit, I didn't say Dr. Kapoor is working.
Yeah, he
Yeah,
noticed.
me and Dr.
He noticed.
Guja don't work. We are here for face value.
It's actually pretty good. Yeah.
That looks great.
Very
That
nice.
looks good.
Beautiful.
So what we're gonna do is we're gonna leave the wire in, and we're gonna balloon with the 7-0 when we get the balloon up from radiology. But I really want to appreciate Dr. Patel and his time, and most of all his expertise for helping us learn together on how to take care of these patients. Thanks, Rahul.
Of course, yeah.
And Srini, thank you, man. Thanks for taking time in Miami to contribute so much as you always do.
Good to see you, buddy.
And Ajit, again, thank you. But also, I would like to thank our team here for putting this together. Shalini for putting together a nice presentation. And we shall sign off, and we'll see you soon.
Awesome. Thank you so
Thanks,
much,
man.
BK. Thank you,
Thanks.
Dr. Patel, Karthik, and the team. Srini, thanks for joining us. Ajit, always a pleasure.